I would love to speak with you. Okay. Looks like we have 100 people, 101 people in the waiting rooms. Very exciting. All right, hi everyone, welcome to the session. We're just going to give everyone about a minute to join in, and then we'll get started. All right, so welcome everyone. I'm Alexandra DeLazio. I'll be the moderator for this session. You are in session IC 15. So you have a few seconds. If you're not supposed to be here, it's IC 15. And it's going to be about the challenges of planning for growth in pediatric seating with Karen Kangas. So without further ado, I will hand it over to her for this awesome presentation coming up.
Hi, everybody. I'm not going to spend a lot of time talking to you about who I am. Some of you already know me. I certainly have been at ISS from the very beginning. And if you don't know me, I'm just a pediatric therapist that's been in the business for a very long time and continue to be active. And we have a lot to go over today. This could have very easily been an all-day session without a problem. I actually teach a graduate course on 60-hour graduate course on pediatric seating. So compiling this down to 1 hour is a challenge. I'm hoping that it will be helpful to you, and if nothing else, really inspire you. And I hope there are a lot of therapists in this group, ATPs and RTSs, not that you are not welcome. I want you to learn this as well, but I'm really, really speaking to the therapists. I want to inspire them. And if you have any questions, please feel free to email me. There are 2 handouts that were uploaded. One is the paper I had to write. If we used to have a little book there, so I gave you a copy of the paper, and you also have a copy of the handout, but not the photos that I'll be sharing with you, because I agree with my families not to give those out. So, but you can follow along. I want to talk about one of the things I have the biggest problem is talking about that pediatrics is one group. If those of you haven't figured out, even when we look at adults, certainly there's a difference in an adult who's 90 years old and an adult who's 40. However, if the 40-year-old has the thing that is in common with them is they both have completed their growth, and they also are already fairly complete people. In other words, the kind of things that they're dealing with are not growth issues, are not inexperiential issues. And although there are things that relate to their age, certainly the difference between a 90-year-old and 40-year-old is great. There are, depending upon their medical diagnoses, still more things alike than there are different. That is not true in pediatrics. And I become constantly distressed that pediatrics is not appreciated for how complex it is, especially since many children I work with don't speak, or even if they wouldn't be able to talk to you about what's happening. And I also have a great problem with us not recognizing how to develop equipment that supports children's engagement in life. And so when we're dealing with this huge range of ages and developmental stages and multiple environments, we cannot possibly talk about a pediatric seat cushion. You cannot talk about a pediatric chair. That is way too gigantic. And unfortunately, most of the time, that is a cut down frame of an adult version of chair that's been around for a long time. We have very, very few, in fact, rare, do we have equipment that has been developed not only anthropomorphologically appropriate for children, but then looking at standards that have involved looking at long-term studies of kids with disabilities. For instance, if we look at some long-term studies of kids with CP, we find that up until the age of even 15, those children with CP, over 85% of them fall into the under 30% standards for growth and weight. And that is how they are. So what will happen is that you can't even say this is an average age for 6-year-olds. And if you've been around teenagers, you certainly know there's a huge level of difference there. There's a huge level of difference with 10-year-olds. We don't really have standard paradigms when we start looking at age groups. So that's one of the things I want you to understand. I also want you to know completely different adult seating in every single way. It requires time and expertise and compromise. By the way, all seating requires compromise. We're going to talk about what those issues are, because I hope these things will help you become better and more able to deal with growth issues. So the other thing I want you to know, pediatric seating cannot be assessed or evaluated adequately in a clinic setting only, nor can it be a single evaluation session. Seating must always meet the needs, and this is what's really different about pediatrics as well, must meet the needs of the parents and caregivers, and then also seating must provide support for the child's development and independent engagement. And a chair cannot do both. The same chair cannot do both. So we have children who have to be cared for, and the parents, we must take into consideration how the parents can manage them. And that's why we have high chairs for toddlers in our traditional lives, is because it's easier for us to feed them than it would be for us to try and have for us to sit on the floor and feed a kid at a little size. However, the seating that's needed to be able to manage their medical issues is not the seating, and in fact is absolutely the wrong seating that's needed for that child to be able to engage in activity. So a single seating system cannot possibly meet the needs of a child and their multiple situations and environments. And more than a single system must always be considered. Now, don't start freaking out, oh, there's funding, because again, even funding issues, one of the reasons we have funding problems in pediatrics is because we've just accepted that. We have not brought to the forefront that children are not adults, that we cannot possibly be in the same funding stream, although we are, only because of traditional habits and only because we as therapists have not stood up as advocates to point out the medical changes that happen in a child that's due to growth. I've actually had funding sources say, well, we don't pay for growth, that's not a medical change. Well, we're going to talk about that in a few minutes. All right, so instead, what I want to say is, our responsibility is first to find what works, not decide how much it costs. We find what works. Then when we find what works, we have to figure out if it works within that environment and in those situations. And then we sit down and we look at what are the compromises. And some of the compromises may have to be funding, but we need to look at all of those. But we do not start out with the compromise. We start out by looking what's available and the needs. So I want to tell you this: inadequate seating and seating systems can prevent a child from developing adequate experiential relationships with gravity and its subsequent control of their active girdle engagement and its consequential extremity control. Now, early on, 25 years ago, we were hoping that seating was actually going to prevent deformity. We actually know that that's not true, because we also know that deformity isn't caused from seating. But I am going to say experiences can be prevented. And when we're talking about active bodies, our kids are in chairs for too long. They are in singular positions for too long. And why is that? Because their parents and they have been taught this is the chair, this is the position, as opposed to really understanding children at all. Children with disabilities are no different than children. They are children, and they need experiences and they need movement. Seating is never stillness, but it is rather supportive of a range of postures that are activity and situationally dependent. So seating has to allow for movement within the seating system itself, and it also must be able to support independent mobility within the environment. So we can't just look at how does this move through the environment. We also have to look at how does a child move within that system themselves. All right, so I want to just give you a quick idea of what kind of seating we're looking for. And this is the seating, unfortunately, that all children are getting. Now, it's not unfortunate they get it, because this is the seating that is needed for parents to take care of them, because it is seating for postural management. So it's how we manage a child's body who is not an independent, mobile person. Okay, so if a child is not yet independent and they are not moving to that independence, we have systems that we manage them. We have systems for babies that we do that. We have car seats, we have little seats, feeder seats for them. We have little play areas, we have little cushions we put around them, where you do all that. Well, the same thing happens when our kids then aren't developing mobility. So the postural management is, we need systems that have them be safe for passive transport. So car seats are fine when we're dealing with children who are under the age of 2, but when we're talking about 10-year-olds who still are having issues, we've got to look at different systems to have them safely be passively transported to get to school. We also need to really look at when you're being fed. We need to have you in a position swallowing can be supported. We also have children that are on many medications, and now many of them either have feeding tubes or have medication delivered by IVs. So we need to have adequate management of that. This postural management does support body stillness, and it supports relaxation. And the way it does that is by ensuring that the body comes in contact with the surface of the seating. So the more anybody, that's anybody, any Homo sapien on planet Earth, no matter what your age is, anytime your body is in contact with a surface, you give into the surface. So that's why we have lazy boys, and we talk about being couch potatoes. A lazy boy has a headrest. It covers your back, your neck, your butt, your legs, and your arms. And so what do? You rest. Our beds do that. We climb into a bed. All parts of our body touch the bed. We relax into those positions. So we are meant, as when our body comes in contact with a surface, we are to give into that surface. And that means we give up our active relationship with gravity so that we can relax. Our bodies can recoup, our cellular structures can get to work. We need to have daydreaming. Okay, so the easiest way to help that happen is through symmetrical postures. Okay, but we also have to recognize that when we're doing this in this one position, and especially when we're dealing with children with tone, this seating is restrictive, and we do use restraints. We use active, judicious strapping that is meant to hold a body part in place to allow for safe passive transport. So in fact, that's going to happen. Now, that's going to be very different when we start talking about seating for function. This is not seating for function. This is imposed seating for management. That is not function. Function is independent. Function is something I'm doing for myself. So the body is not active. It is not actively engaged with gravity. It is passive, and it is intact, and it is in the sensory processing mode of tactile processing. However, we need for the child to be engaged in any kind of activity. So that includes, that's all of life, all waking hours of life requires an independent control of movement. There must be the ability to have pelvic stability, which is pelvic mobility, not pelvic stillness. There has to be weight bearing, especially at the pelvis and lower extremities. And in those positions, when we have the use of gravity in our body, that supports task engagement, supports visual convergence, girdle engagement, and intentional cognitive focus. You cannot have intentional cognitive focus in tactile processing. You can make yourself try and pay attention, but it is flirting and you're easily distractible, okay? The body is active, it's in vestibular processing, and it moves. It requires an upright position. And that upright, independent, active movement, by the way, is the only way that we support full lung expansion. And that cannot happen when you are resting against the back of a chair. You cannot fill your lungs. Now, I've practiced hatha yoga for over 37 years, so I can inflate my lungs in any position. I know how to do it. But when I do that, I have to do it consciously. That doesn't give me cognitive focus to do anything else. The cognitive focus is inflating my lungs. If, in fact, I want enough respiratory support to be able to be engaged in activity, to have any kind of endurance, to be involved in any kind of activity, I have to be active and I have to not be resting. And that means the body can't be in contact with the surface of all parts of it. So seating has to be flexible, parts have to be removable or drop down, and the hardware has to be pediatric, not adult, and it has to allow for trunk rotation. And this is where people get very confused. In order to move, we don't just move by falling forward. We activate a weight shift and we find gravity. We need gravity to move, and we move to find gravity. And that always requires rotation in the body. So it means the pelvis makes a shift and it rotates. It shifts to one side of the ischial and rotates farther. The trunk has to rotate, and only through trunk rotation is there girdle engagement, Okay, so if I've got somebody strapped in a seat and I have trunk laterals symmetrically attached and I then have a chest harness on, where is the trunk rotation? And it is that rotation and girdle engagement that controls the extremities. That means there will be more weight bearing on one leg than the other to support that rotation. There will be one arm more engaged than the other one more stabilizing, and the head will come under complete control. None of those things can happen. None of those things can happen in the imposed seating with restraints. And yet, in order to be able to have seating to be flexible, it is far easier to have more than one seat. So we have a seat. We don't wake up in the morning and pick a seat that we carry out to our car and that we bring to the restaurant we're going to and we carry into the house of someone we're visiting. Where we go, and we join the activity, we join the seat. By seeing the seat and the activity and making the transition into that seat, it tells our body what is expected of it. And our children are not getting these experiences. So the most important thing about planning for growth in all pediatric seating, and it actually is the most important thing in all seating, is fit, 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 fit. Did I say it again? Fit. Okay. Therapists need to identify and know a child's growth patterns. And that's a typo. I'm a very good speller. And know a child's growth patterns and observe them and track them over time. So that's one of the reasons. Too many times our kids are given seating before you know them. Now, when children are really little and they can be in car seats and some traditional strollers and everything like that, you already should begin to be tracking what their growth patterns look like, observe them, and what kind of patterns of movements they're utilizing. Because what's going to happen is that's going to help dictate what kind of seat we're looking for. We do tend to know that children with disabilities tend to not grow as large as children their own very specific age, but this cannot be predicted in advance. So if anybody tells you this system can grow, they are giving you an arbitrary growth that might as well be mama bear, papa bear, baby bear. It is small, medium, and large, because I'm here to tell you every seating system is still moves in inch increments. And if we're talking about children under the age of 5, we should have half-inch increments. And why? Because we have just cut down frames of adults. And so somebody says, well, here's a system that'll grow. It'll be with them till they're 10 years old. We're just going to put a little tiny seat on it when they're little. Okay. Well, that may look okay to a family who's used to a high chair, but you've now given a child a seat that has to go to school with them, and they cannot possibly have a peer relationship. They cannot possibly be under a desk, and giving a kid a tray is absolutely not, now let me say this again, giving a child a tray is not a learning relationship that would be the same as if they would join their peers and be as close to them physically as if they were sitting in a traditional classroom chair. This is a huge mistake that people do not understand development. Children need to be near each other, touching each other, and they need to have their feet on the floor. Their feet on the floor, not on leg rests and foot rests. Here's a clue: foot rest, leg rest. I already told you, rest is imposed seating. We want active engagement. That means I need to place my foot on the floor. I need to place it and help hold myself, and I need to be able to rotate from that position. So what needs to happen is we need to understand, if you are getting a system because you believe the child will grow into that, I am here to tell you that system will always be wrong. You need to fit the child where they are now. Especially when we look at trunk laterals and hardware, hip guides and hardware. There is not pediatric hardware. I will tell you that, yes, a company, AEL, did try to do some pediatric hardware a while ago, and there has been some on the market through Freedom Designs, but nobody has really taken this under consideration of really understanding what we're talking about. When you look at trunk laterals and you look at swing weight trunk lateral, that swing weight trunk lateral is the exact same hardware that is on an adult who can weigh 250 pounds, which means that when we put that on a child and we put on the same trunk lateral pad, that trunk lateral pad, by the way, is an inch deep. That means when I put it on a little baby, it forces their arms away from the body. When the arms are forced away from the trunk, the trunk will collapse as the shoulders will internally rotate, which will then cause a lack of head control. So the very trunk laterals you put on can cost head control in terms of active engagement, because we don't control the head by being supported symmetrically. We have to rotate the trunk, and that helps control our head. And so when you see children trying to pull their arm inside the trunk lateral, that's absolutely appropriate for functional seating. We don't have our arms hanging out. I would just like any of you to sit and think, move your arms away from you and not have them not touch your body for some activity that you're doing all day for 20 minutes. You may not touch your trunk. You may not touch your trunk. We all touch our trunk. When we reach to pick up our phone, we actually go, when we are holding our phone and texting, we move against our trunk, because when we move against a trunk, that is the sensory processing that gives clues to our hands about how much effort it must do for graded movement to maintain the hold on the phone. So we are preventing, by the trunk laterals and using adult-sized hardware, as we are putting a restraint system costing children experiences, because understanding how those things interfere with independent movement. I also want to tell you that we've fallen far too in love with contouring. What does contouring, now nobody is really measuring contouring, so you are not developing contouring based on your knowledge of the child's patterns, because contouring forces you to have multiple contact with the chair. Instead, what I would prefer that we would have, we can replicate more open, free seating and replicate the joys of contouring without the deficits of contouring, because contouring doesn't grow, and contouring imposes a predetermined pommel and thigh channel that forces you to be in that, which then causes actually the pelvis to go into a posterior tilt. All contoured seating supports a posterior tilt. It doesn't, no contoured seating supports an anterior movement or rotation, because in order to rotate, you can't have a pommel. So you actually need a flat surface. Now that flat surface doesn't need to be a rigid surface. People say to me, oh, she's so old. She remembers that old planar seating that we used to do years ago. No. I want new foam. I want memory foam. I want the seat to be comfortable, but what I want it to be is I want it to be able to accept where the child needs to go. So when the child is active, I don't want a pommel. I don't want one drop down. I don't want it on at all. I want feet to be able to be on the floor. I want them to be able to move forward out of the seat if they want to. I want them to be able to move back. I want them to be able to scooch. I want them to be able to do rotation. And people are saying, oh, well, I work with kids who can't do that. Well, I work with the most kids with the most complex bodies, and all of them can do it over time if they have the experience. And all to a one of them, they will gain head control, cognitive focus and attention, visual attendance, and they will be able to actually gain control of their body because the girdles are engaged. So when a child grows and the chair size has to change, this actually is a medical status change. So don't let anybody tell you, we can't get this chair because they're going to grow out of it too quickly and there won't be funding. It is true that the funding won't come automatically. All funding sources tell you is if you wait 5 years and you order a new chair, we aren't even going to ask that maybe you could have still used the chair you have with a new seating system. It's okay, because just push it through, because 5 years, we're there 5 years. Okay. Well, I want to tell you the difference between a 2-year-old and a 7-year-old is huge. The difference between a 5-year-old and a 10-year-old. How about a 10-year-old and a 15-year-old? We can't possibly, no, we cannot have predetermined time guidelines on our children's seating, or it will always be wrong. So instead, what needs to happen is, as a child starts growing out of their system, you don't now call up the medical supplier and insurance company and say he's growing out of his chair. You now determine what medical status has changed. There's pressure on the thigh. There's not enough support in the trunk for adequate swallowing and respiration because the back is no longer supporting enough. It's too low. We need to change the seating because it is no longer adequate to support adequate lung expansion and respiration, swallowing, to be able to maintain adequate skin integrity, to promote and accommodate any orthopedic anomalies or upright postural control. There's nothing more medical than all those things. And if a child is beginning to grow out of a system, those are the things. So growth in a system is actually a medical status change. And a medical status change is always a reason to change seating and for that seating to change. Okay, so I want you to understand, how do we look at equipment then? Well, first of all, families and therapists must decide this together. I know RTSs and ATPs are saying, where are we? I don't want you in this to begin with. I want the families and therapists deciding together first, because ATPs and RTSs, a lot of times as your medical suppliers, you don't get paid for this time. We're going to involve you, but not yet. You have a very important role, but not yet. Families and therapists need to decide together what is the most critical seating system needed. What characteristics and what seating systems are needed for what activities, okay? And when you have identified what those are, then you share that with the ATP and RTS, because you need to look at systems. You should never be taking one system. You need to look at systems, because every system has something you want and something you don't want, okay? And you need to look at all the environments. Therapists, you have to look at all the environments, not just whether somebody's being transported. You need to know about the school, and you need to be home, and you need to know about the community. Where is this kid traveling, and what are they doing? And did you look at the bathroom? And did you look at the, but too many times our chairs are too big and are not fitting into a family's home. Or not allowed to be at the family. I find it unbelievably horrible that we still have seat to floor heights that were developed for quads who were men, who were tall, who were young, and that's still the seat to floor height we have in pediatric seating. And we aren't even doing dropped seating with J hooks even in terms of the frame. So our kids cannot possibly join the table, okay? So in the beginning, we need to explore all these things. So when you start to explore that, you can see you can't do that in a clinic. This can't be done by interview. You've got to look at it. You've got to be in there. You've got to see these things. Oh, I have not seen another typo. Rarely does any funding source or manufacturer develop equipment for pediatrics and have growth based on real information, or a child's development, or any accessibility or inclusionary practices. People do understand universal design, but they don't understand accessibility and inclusionary practices. I still argue when I have to look at accessibility issues when I work with adults, because I cannot believe that people think a ramp is just supposed to have a 90-degree turn on a house. I want to tell you, I don't know how you actually when did we decide there couldn't be roundings? Where did we have a ramp end that just ended at a certain width and you just dropped off? Where was the openness? If you start looking now, where, thank God for Target, you know, we actually don't have a curb cut. We have the curb laid into the level of the parking lot. So now it's flat for everybody. We don't have to go looking for a curb cut. Well, the same thing has to be looking at home. We need to be looking at how are children included in activities within their home, within their bathroom, and within their schools. So as therapists, we're going to be forced to compromise already in a seating system and chairs as we try and match the needs of the child and we try and look at their functional independence. But a child cannot be functionally independent in a high chair. In fact, when children even start to sit in a high chair and start to feed themselves, they quickly need to be moved out of that high chair so that they can be more at the table in terms of being able to feed themselves. Well, the same thing is true of any functional independence. A chair that is meant to be able to encourage relaxation, safety, symmetry, restriction, so that you can get passively moved from one place to another. Or if you are being fed, you need to be relaxed. Okay, so yes, that's tilted, symmetry, all of that. That's really important, but that same system cannot possibly then be thought of as the system that a child is going to learn in. Okay, so when I'm planning with families, I actually like to do this. I don't try and bring in chairs and say, you're going to love this, you're going to love this, you're going to love this. No, I want to teach everyone the issue of feature match. So that means you may not know, I do know the brand names of chairs. I'm not here to impress you because this is my life, but you don't need to know that either, but you do need to know characteristics. So first of all, I create with families a hate list. Now, when we're starting with really young families with their little babies, they don't have a hate list yet. They do have a problem list. They'll say, she's getting too heavy to carry, or I wish I could do this. But every family you work with that's had a seating system at all, they have hates. So the very first thing I do is start the hate list. I want to know what the characteristics of the seating system that the child is using that you hate. It's too big. It's too heavy. Well, it works for me, but doesn't work for my husband. It's too hard to transfer in and out of. It won't fit in the bathroom. Well, I don't like this because it doesn't hold her up straight, or it's not really easy to feed her in, or it won't fit in the restaurant, or it's too hard to break, or it won't fold, or I can't use it outside. I was really hoping when we could go into the soccer field when her brother's playing, I can't take her into the soccer field. You know, we live on an incline. This is really hard to push, you know. And I want every hate that's possibly imagined. I just want it laid out. And then I want a wish list. Okay, so we just put that aside. Now we're going to do a wish list. So what characteristics do the wish system contained and were available? This is truly a wish list. I want a wish list. I wish it could fold. I wish it could do this. But I don't just say I wish it could fold. I want to know why. Where do you want it to fold? Because what is it that you want it to do? I wish I had something that would fold easily so that I could take my kid grocery shopping with me. I wish it could fold so she could go visit her grandma more often. Okay, so it isn't now just a characteristic for a characteristic. Up the hate system, we told me real reasons. It's too heavy to push over, blah, blah. It's too hard to do this. Now the wish list is going to be the same thing. So it doesn't get to be, I just wish it were prettier, lighter pink. Okay, so what's going to happen is you want to develop a wish list. Now you want to identify all the daily activities of the child. So that includes getting up in the morning, where they're fed, how they get dressed, and all the things during the day. So therapists, you see, this is not a simple seating a clinic where I'm just going to check and see what your seat width is and your leg length. All right. So, and then we need to look at all equipment available to meet the needs of the child and his, her, and her activity. And that's with your RTS. It may not even be with the family. You may go on the internet. I don't care how you do it. You need to know which ones are there. I wish you could say, oh, this would be 50 systems. It isn't going to be. It isn't going to be. You'll be lucky if you get 5 to 10 systems. Then you need to realize together that one system won't have all the needs met. And what are your compromises going to be? What did I tell you before? So compromise can also include funding. But I want you to remember, our kids are in school. We provide some systems in schools. We have some systems that we can look at differently, but I can't teach you all of that today. All right. I just want you to understand. So what I want to do is let's look at a few kids. All right. So here's a very popular system. Okay. And it's a tumble form and it's a feeder seat. So what is it? Feeder seat. Here we go. Feeder seat. So if you were being fed in the feeder seat, you would be tilted. You have a lot of contact with the surface. And this is an attempt to try and make this feeder seat be an active seat and try and bring, this is little Lewis, try and bring Lewis's feet on the floor. Well, we can't even bring it up high enough to bring him on the floor. We can't offer supports in doing that. See, you've got a pommel that's predetermined. It has to be forced into a symmetrical posture. So this seat. We then have developed the tomato seat, which is a tumble form that's now on wheels. I do not have a problem with those being relaxation systems. Don't get me wrong. They are not systems for active learning. Okay. So here, when I want to move Lewis and I'm going to move him onto the floor at exactly a position that other children would be in, and people are saying to me, oh, I thought you were going to use the bench. I am using the bench. I'm using the bench as a table surface. Because what I'm interested in is that he starts to have some experiences that children his age do. He's 2. Why would we be having him? If he were sitting on the couch, he'd be in the corner of the couch. He'd be propped in the middle of the couch. Even as a 2-year-old, he wouldn't always be able to make it climbing up onto the couch on his own. So what happens is that how do we, when they're really little, easy that we can start to use the floor and we can create systems within an environment. What I can't believe is that when people recognize, and this, by the way, is one system that was developed for pediatrics with real data, okay, and that is the Kid Walk. However, still it's to market. I don't like when it was in the beta testing and all the testing of the systems, they built the seat part of it that's under the butt for each child. So we only have 3 seats, so a lot of those have to be customized. But anyway, so what'll happen is the whole point of the Kid Walk was that children could be within their environment and use their hands. So we were going to have a walker that allowed mobility, and that's why you have the big wheels aren't there for you to push. The big wheels are there to allow the system to move over carpeting and onto linoleum without a problem. And you can put your hands on them, but that's not what they're there for. The other thing is that the kid walk was developed because kids don't stay in walkers all the time. They walk up to something and they sit down, and they sit and they stand, and they sit in the stand. And the kid walk allows you to replicate that. It can't totally do it all on the child's by themselves, but you can do it. So there's one other thing. When you see Lewis here, you see he clearly has got head control. You can also see that he's taking a step, some very purposeful, intentional movement. Guess what? We then have him get in this walker and we tell him just to walk towards us. We still don't recognize this is the seating he needs to have independent functioning throughout the day. So we can have a headrest there. We can move him into a posterior tilt, an anterior tilt, or neutral. We can move him into a seated posture and upright. And if we plan this well, this can be much of his day seat. He can then get out of this to be able to be fed, and then we can bring him back here. So we can actually use a mobility system as not only a dynamic stander, but it also can be a seat. But we've got to change the seat, and we've got to look at that seat and make sure it can happen. And it's going to allow him to gain control because he needs this much information to gain head control. Head is the first extremity that gets control. And so, yes, he's excited to move, but it's not just exciting to move. You want to move to get close to something, to look at something, to touch something, to find something, and explore it further. Here's Bennett. Okay, so Bennett is in first grade. All right, and so here we are. And so again, I'm actually asked to go in there and help develop access for an augmentative communication system. And I'm saying, well, clearly I want to use his head, but this seating system is not fitting him. Well, yeah, we know. We think he's outgrown it. Not think. Okay, not only is the seat too short, his legs aren't supported at all, and then we've got him trapped back onto the leg rest. If I take these straps off and I flip out the leg rest and I let his leg hang, okay, his foot is 2.5 inches lower, okay? So, and because we make this seat is attached, the back and the seat are attached together, just in the classroom can't move that forward or move the back higher or what's going on. So what's happening is he's attempting to go forward. He doesn't have, you can see his pelvis, if you look carefully, is in a posterior pelvic tilt because this is the system he rides to school in. It's so symmetrical. So he attempts to throw his head forward and then he doesn't have control because the pelvis is non-weight bearing, okay? So same thing, we put him in, they didn't have a kid walk, and believe it or not, most of the Riften walkers, the newer ones, you can actually reverse them so they can be hands-free walkers. By the way, you have to contact them sometimes. It's not just a simple fix. And they have less of a seat. But what will happen is, what I wanted to show you is, no one doubts that he has head control, okay? Oh, but here we do. See? Oh, he doesn't have head control. He doesn't really lift his head up because we somehow think he's supposed to lift his head up with his neck. You don't lift your head up with your neck. You lift your head up with pelvic weight bearing, okay? So what'll happen is here, why are we not then assessing the use of him using a communication device from here? Why are we not sorting out a way to be able to mount a headrest with some head switches here that he can go approach a system? Why are we not having him, in terms of doing that? How are we looking at this system to be not a walkout in the hall? Mobility out in the hall is okay, but that is not pediatric. Everything in pediatrics is about the child's intention to be engaged in their environment. Learning is about being involved, okay? So what will happen is that when the seating did change, and we now, here you can see, like I said, see where the hardware is? If he's sitting back relaxed, his arm is right over that hardware. That's what bothers me. And even so, we cover it up. In fact, this same hardware for me would be behind me. My arm would be in front of it and would only be on a pad. But at any rate, I just wanted to show you is once we altered the seating and got some adequate support, and we only strapped in one foot to begin with, we loosened the chest harness. He started getting worried when it came completely off. I'm not saying take everything off at once. I'm saying we're going to figure stuff out. I wanted you to see that, in fact, he can, with having there are proximity sensors in here, his head within the headrest, he's able to actually manage 2 switches, okay? Next, I want to show you something classically there. As you know, again, when we're talking about inclusionary practices, this is not an inclusionary practice. Him sitting in this seat and everyone else is sitting on the floor. Well, we have floor sitters. No, I will tell you how I help with this as a therapist in schools. This is the time I hold him. I sit down and I have him and another kid sit on my lap. I take turns with who's sitting on my lap. but we aren't developing systems that fit down there. If we have systems that'll fit down there, it should fit every one of these kids. He looks like he's much bigger than them. He actually isn't, but he's all the way up here. So what is he seeing when they're reading a story and the rest of them are all down here? It's not the same experience. Okay, so the same thing happens. Here's the teacher, here he's at this level, but all of the other kids are down here. So how she approaches and we think of inclusion is that he gets to be there. Inclusion is not the fact that you're in the room. That is just a drop in. Inclusion means we've supported a universal experience by allowing you to be engaged in activity as everyone else. So same thing. Now, because this is your classroom chair and it's too high, God forbid your feet would be on the floor. It still has to be on a foot plate, because I don't know why we can't put your feet on the floor. So now you can't even sit at a regular desk because this is too high. Even so, this is the small chair. This with its footrests on there and how it's made is too high for you to go under the desk. So now we have to support lifting up your computer and have a different way. So you can't even be sitting next to somebody's desk. Why is this tray acceptable? I find them horrendous because children learn by being near each other. Pennsylvania is one of the biggest homeschool states in the United States. And I want to tell you, when homeschooling became really big here, which was about 20 years ago, everybody was panicked in the public education system that kids were not going to academically perform. Well, not only has homeschooling done well for academic performance, but I'm here to tell you this. There isn't a homeschool now in the state of Pennsylvania that doesn't have group activities. Because do you know what homeschool just got figured out? They figured out that it isn't just academic learning, that children need to have experiences with other children for life experiences, and that their learning is enhanced. And yet do you understand, this seating system is isolating this kid from having relationships with children. He's not sitting in the same kind of chair. He's not close to them. And if he needed some support, he doesn't need all the support. Because look, he's away from the back. Why are these? He doesn't need those trunk supports. He's leaning on this tray. Why couldn't that be a desk? Because we have not developed seating that actually supports real learning. I want you to meet M. M actually has dystonia, and this is M's body under control when she was young. You can see her head is propped away. This is working with her. Okay. And so when I put her first into a kid walk again, everybody was like, oh, well, see, we all thought she'd immediately have her head up. I'm showing you these pictures because your head dropping does not mean that all of a sudden a seating system means your head's up and up all the time. Your head is up and down for many, many reasons. I'm not going to go into all that detail. But here is a child put into a system, but she is not engaged in activity. The activity is this same therapist, there's her feet, saying, come over here. Well, who's controlling that activity? The therapist. Let's instead do a child activity. So instead, I'm not going to ask her to move it. I'm going to bring her over to a table where the other children usually read a story. And I have a storybook out. And she can come absolutely there. I can make this system move down into a seated system. It doesn't have to go all the way down. So her legs are actually supporting her. And guess what? As her legs support her and they support her pelvis and girdle are both engaged. So she has head engagement. And now she's actually here. Everybody's like, oh, well, look, she's really happy. Okay, yeah, she's excited to be at a regular desk, at a regular table. Now she's engaged. So I can bring other kids literally right next to her and she can be doing the exact same things as they are doing. So I just can't tell you enough how important it is for us to understand that. I want you to see that, just also see this system can certainly be a walker. It certainly is meant to do that, but it's not meant to be walker for walking. Even a walker for walking, I want it to be inclusionary in terms of what's going on. Growth can be built into that, but I want to tell you, it took us 11 months of working through with her school and her family to get her into a system like this. She hated all the systems. And do you know what? Once we started looking, she has dystonia. And I want to tell you, kids with dystonic cerebral palsy have the fiercest and wildest bodies. And so this is a quiet time. She can at any moment have a surge of tone. You've got to make seating that accommodates the surges without having her fly out. And even in terms of restraints, that there still is looseness that allows her to go through the surge and come back to center. Okay, so what happened in 11 months as I was able to look at her is she definitely needed one leg strapped in, but she could not tolerate straps over her shoulders. She didn't know that. She couldn't have told me that. But me working with her, every time I moved a strap over her shoulder. So she only wears a diagonal strap on the bus when she has to, like you and I do. But if she has double straps on, her body cannot take it sensory-wise. So we use a chest strap during the day. with that chest strap and one leg in, even if she has a surge, she does not fly out of her chair. She doesn't bang all around. She has the surge, and the surge is not met on a tray. If a surge of tone hits and there's a tray on and it bangs against the tray, then it forces the body back, which then hits the head. And then everybody goes, oh, well, we need springs in their systems. Well, I'm going to tell you, dynamic spring systems do not accommodate surges because surges don't happen symmetrically and surges don't happen in the same way. So if a kid has a surge and they know that's a part of who they are, it's like if you have a twitch, it's like if you have a shorter leg, you learn to accommodate that. How are we helping our children cope with the tone that they have in terms of their bodies and understand it? We have to build seating. So it took us this, you're going to say, well, that seating system doesn't really look that much different. And you know why it doesn't look that much different? Because you don't know the things of things. I had to battle to get this pommel this size, an actual exact fit pommel that would fit her and that it would be removable. So it could drop down and be under when we needed it. And we could have her feet be able to be flat on a flat surface for her legs. And at the same time, have one of the hip guides more open, one closed. Still we have a pelvic belt that goes inside around her body to the back. And we have another one that's a seat belt that goes to the outside frames of the chair. We have a chest strap that fits in between the trunk laterals, and she only uses one trunk lateral and this leg down. And then we do have the headrest there, but she does not like the headrest because this kid cannot stand to be tilted. There's another thing. So everybody was trying to tilt her. No. So it took us 11 months to figure that out. And here is the 12th month. Now, all of those 11 months, we were already working on a manual board with AAC. So she was learning the symbols. And now on the 12th month, when we actually started looking at a device, she not only was able to manage looking at the device, she was able to tolerate 5 degrees of tilt to help accommodate better lighting in terms of her managing an eye gaze system. This is the beginning of her using an eye gaze system. Okay.
All right, hey Karen, I'm just gonna hop in really quickly. It's about 15 minutes to the end of the session. So you have about 3 questions in the chat if you wanted to answer those or just keep going, either way works.
Keep those, and will you interrupt me at 5 minutes? Okay.
Absolutely.
All right. So I also want you to meet another young boy. Okay, so here he is, 8 years old. He's in an inclusionary setting, and I actually have been asked to see him because they are thinking he is not, he's not really focused or cognitively focused. So everybody's worried about how can he academically perform. Well, I am always looking at seating as it relates to everything. So you can see he is in a wedge seat. Oh, that was the other thing. Let me just back up. The other thing that I found with M is she is on a flat seat, but that flat seat is, first of all, still 2.5 inches deep. The bottom inch is a medium soft memory foam. The middle version is a soft memory foam, and the top ½ inch is standard foam, so that she literally feels like she can sink in. She has very little tissue over her little bum. And that's what she told me later on as she got older. She was able to tell me, this is the only seat I like. It feels good. And I don't like the straps on my shoulders. Okay. Now I'd already figured that out, but she could then start to tell me that later. Okay. So what'll happen here is this kid is in a contoured seat. The pommel is a standard size. He has broken his leg rest because when he has a surge of tone, both legs push out. And when they do, so do the extremities. And by the way, when extremities move bilaterally and symmetrically into extension, including internal rotation proximally, which you can see all 4 of those are, that's telling you that both girdles are feeling unstable. That is not a CP pattern. That is not a reflex. That is a human protective movement when the girdles are unstable. I don't have time to teach you all of that today. But anyway, then as he attempts to rotate, he falls outside of the headrest. And so everybody then all day long keeps shoving his head back in the headrest. He's broken off the leg rests because as he has attempted to move forward and he falls forward of the contour, his butt is hanging in the air. When you see him from the side, he's still attempting to do that rotation, but now his legs crossed, his arms have crossed. And the reason they've done is because he's hit the obstacle of a tray, right? I'm told he does not have head control. He does not have visual tracking. He has no visual focus. He is not cognitively attentive. All right. And as usual, when we have a tilt chair and we have these extensions that we put on, which by the way, I hate, and I'll tell you why I hate these. You may be a tall person and that you need this extension to be able to push so that we raise this up. But the farther away the push handle is from the actual back of the chair, the rockier the push is. So our little kids with little tissue on their tiny little bums are getting bang, 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 bang overall surfaces because we've added this different extension, which by the way, places you at least 12 inches from the back of the seat as you're pushing. So you already are making that a rocky surface. That's just an aside. At any rate, so I'm going to, with him, I'm going to take off the headrests, the trunk laterals. I'm going to flatten the seat. I'm going to take off the pommel and take off the leg rests. And when you see him here, is there any doubt that he has head control? No, not only that, he has a little bit of rotation, but you can still see he's got a collapsed trunk and he does have in a posterior tilt. Well, why aren't his feet on the floor? Why can't I get his feet on the floor? Because this is a seat to floor height. We find this totally acceptable. How have we, as pediatric therapists, found that this is an okay seat? Why is it this high? This is ridiculous. This is the same exact height as a chair would be for me or any teenager or adult. So he can't be at the desks here. Well, that's okay. I'm going to put him there. So what's going to happen is I'm going to move him in a standard seat and not now in a symmetrical posture. I'm going to purposely look at pelvic rotation. I'm going to look at weight bearing on one side. I'm going to be using his dominant ischial. We're going to look at where he rotates. And I already had open, this is the teacher, I had opened the book of what I saw was the homework assignment for the kids. So I had the book open there. When I moved him into this position, he put his fisted hand on the page, on the book, and pushed over 3 pages and then stopped and looked at it. And this teacher then said, oh my God, he's right. That's where we're studying. I didn't change the board yet. So what happened is he actually knew it was going, no one had any idea he had this much control. Okay, because what happened is this was supposed to be, not that, this was supposed to be the correct seat for him all day long. All right, let's just look at somebody else again. Here, let's look at a 20-year-old, okay, who again, we have a tremendous seizure disorder. Everybody thinks she is tremendously not cognitively focused, not visually focused, because she has seizures a lot, so she's on a lot of medication. And I was like, well, when you bring her in, she has no head control. You know, you can see that she's got disuse atrophy in her upper extremities. She has contractures, hips, knees, ankles, shoulders, elbows, hands. Okay, so she doesn't have head control. Well, I'm going to take her out of there. I'm going to put her feet on the floor, and I'm not putting her heels on the floor because I can't bend her ankles because they're already contracted here. But when she even so is in this position and we've got a 90-degree angle there, she actually needs to have a more open hip angle because she's got a pretty compromised scoliosis. So when I move her back till we can actually get weight bearing, and what you can't see is I've angled against me, I can be the perfect seat. So I've actually pushed this shoulder, I've allowed this shoulder to go more forward, this shoulder a little bit back, the pelvis is slightly rotated. Does she have head control? She absolutely does. Okay. Now, is she going to keep her head there without dropping her chin? No, she's not doing anything, because if you can see me, if I stop it, I put my hand, as soon as I put my hand here, although I'm forward in my chair, I'm actually leaning on the desk and I don't have head control. If I want my head to have control, I shift my pelvis and my head comes up out of my hands, and now I have control because I'm engaged in a particular activity. Let's look at the same thing here. When we start looking at Juliana, okay, so Juliana, same thing, 19. Everybody's like, well, she has 90-90 seating. No, she doesn't have 90-90 seating here. And even at 90-90, she's trying to get her foot back to get it under her butt, okay? And so what'll happen is when I actually moved her forward in her seat, I found that actually the back isn't at 90, it's actually reclined. And what was happening is as she kept moving her head to the outside edge of her headrest, and the therapist said, we don't understand, she keeps moving her head there, we push her, keep putting her head back into the middle of the headrest where it belongs. Well, no, what happened is when we took the straps off, when I let her legs drop where they needed to be, and I moved her shoulders up over her pelvis, and she clearly held her head, guess where her head was? Her head was here. Because if she has her head in the headrest, she's fallen back into here and she can't pay attention. She's another kid, then I'm going to move her into a chair, again, not sitting forward. I want to allow one leg to be more weight bearing. I want there to be some pelvic rotation. So I'm going to help that rotation by sitting on the chair angularly. I'm going to allow the support to be there and move her into regular desk. This is the surprise. But I'm going to tell you, she told her mom later, they use a different form of idiosyncratic communication, that she was happy because she sat at a real chair at a real desk. Okay. I want you to just now look at some in terms of one more compromise. We look at these standard tilt systems, and what we don't recognize is that the tilt systems were developed actually for an anterior tilt. And although we have these collars here that allow us to move into anterior tilt, we rarely use it. And so I just want to show you again, this is a teenager. She's 14. Everybody said no head control, doesn't have control. She's broken her legs. She's got those wonderful pneumatic spring mechanisms. So yes, they've been on there. But I want you to see her knees are in her feet have to be pulled out in front of her legs, because in fact, this leg rest and its articulation and where her seat is don't match her body. Okay. So I'm going to take off the leg rest. Whoops. I'm going to just take off the leg rest. I want to get her feet on the floor. I want to move her into an anterior tilt. I want to take off the head rest. I want to take off the arm rest, and I want to bring her to a standard table. Okay. And so when I do, and feet can be on the floor, look at her here. Now, I do want to tell all of you, when I show you these things, I don't want you to think that you can immediately run back and every person that you work with, as soon as you put their feet on the floor, magic happens. I am going to tell you, though, of the kids that you work with, all the kids you work with, half of them this will work with this easily. Okay, now easily doesn't mean I just threw them in these positions. I talked with them. I already studied. I knew what kind of activities were around. I got to know them. That all happens. But I am going to tell you, when it doesn't happen like that, inevitably we have some other medical things going on. We have some other processing issues going on, but this is still where I'm headed with everyone I meet. Okay, Alexa, ask me the questions.
All right. So someone asked, how do you figure out these things when you aren't the therapist interacting with them on a regular or daily basis? So providing an outpatient seating clinic and not ongoing therapy intervention with the patient.
Well, I think that's an easy answer. You can't. And so what do you remember in the very beginning slides that I said in pediatric seating, the clinical setting cannot be where you do your seating assessment. So what has to happen is, when I worked at Hershey Medical Center and I did develop an assistive technology program there and work with complex kids, I worked with the seating clinic. So I worked with them, but I went in and did more than what they did. I didn't go in to see them till we already knew what seat we wanted. A seating clinic will never serve pediatrics well, except for imposed seating for safe passive transport. Now you can do that. You can do imposed seating, which is safe passive transport. If you've got a feeding tube, you can do that, and that's needed. Don't get me wrong. The only trouble is, depending upon what you choose, if you haven't worked with the family of then looking at more independent, choose a system that by its very funding alone prevents them from getting another system. So you are in a quandary there, but I will say you can definitely provide the adequate seating to get them safely to school, okay, for the families to manage their bodies. You can do that from a clinic setting. You wouldn't actually have to even see the kid for that. I mean, honestly, that's how direct that is. But you want it to be fit. That's true. The trouble is, I want you to extend your knowledge now and say, this can't be the only thing we do. We have to develop a relationship with others, with school therapists. I have to understand, as a pediatric therapist, I'm fulfilling one little tiny role. And if the only thing I do is say to families and to school therapists, you're going to need more than this. The kid should not be in this all day. Okay. So I'm hoping to expand your knowledge, but you can adequately, in a clinical setting, provide imposed seating for safe passive transport, but you cannot do the independent stuff. Okay, next question.
So what is the minimum and maximum time requirement to deliver a wheelchair? Start by assessment and end in the training.
You can't possibly, I would, if I saw you, whoever asked that question, my first question would be is, first, how long have you practiced? Where did you go to school, and where is your mind? Okay, now I'm not trying to be a smart aleck, I'm just a direct person. Because what I want to say is, how can you possibly answer that? Okay, is the kid non-speaking? What are the medical issues that are going on? What are the family things going on? And also, if you haven't figured out yet, we have no control. When we write a report of medical justification and then the doctor even signs it, and by the way, I used to control all of that, hand carry it to the doctor, have my family's hand carry it to the doctor, and then we have to submit it. We have no idea how long the funding source takes before they give it. Then we now don't have any inventory, so we don't know how long it's going to take till somebody provides us with that piece. And then trust me, medical suppliers, when they first work with me, do not like me, but then they learn to love me, because I will tell you, I make sure everything gets paid for. But in the beginning, I may use 4 different companies. I don't just take, oh, we want this system and everything from there. So all of them have to come together. All of those are issues. So don't put a time limit on it. Instead, do the work. Do the work. Okay. So the work is going to be, I'm going to go this far, and the kid is tired and the parents are tired. I used to tell people when they would travel to come and see me at a medical center, because again, I didn't like a medical center either, because I told them I would come to visit their home. I would tell them, you're not coming to see me once. You have to be planned to see me at least 3 times. Now, we could often we might be able to be done sooner than that, but don't decide that in advance. Decide in advance, I'm going to do the work. And if you guys want to borrow, I have developed a pediatric assessment that includes all the things that I look at. I'm happy to share that form with you. You know, email me with questions. Also, ask ISS, could we please, if this is really important to you, I'd love to teach this for a day. You know, and I'd love to have us really get some equipment and do comparison and contrast and help you figure out feature matching and looking at characteristics of equipment and how you can identify for older kids trying to compromise a system or not. You know, man, I would really love to teach that. Every time it hasn't been a real interest at ISS. So if that's something there, please, please, please let them know that. I would love, love, love to help.
So Karen, in the chat, a lot of people were requesting that, as well as your contact information. If you could put that in for everyone.
Well, I was going to say the contact information, you could get it on the handouts.
Okay, perfect. Which are also online, and I will quickly just tell everyone the CEU
and
code.
Just email me if you would like the form. Like I said, you know, if you would like the form, I don't have a time limit on it. It's just all the things that I look at. I'm welcome. You may use it. Let me get all the way to the front.
All right, and while you do that, I will just let everyone know the CEU code for the session is GR2 GA7. Again, that's GR2 GA7. All right, and Alyssa has put that in the chat as well for everyone, so I appreciate that. All right, so thank you so much, Karen. There's so many awesome comments in the chat, which we encourage you all to make sure you look at those and do all of that. So thank you so much for the session, and any additional questions?
Have a good conference, and I hope we will get to see each other in the future. And if you do ever see me in the future somewhere or near the bar, although I don't drink that much anymore, but that's usually where things gather, please come up and talk to me at any time. I really, the reason I'm even try and squeeze all this into 1 hour is I want you all to grow and learn. We have to help our kids more. And there's no quick book to do it. I am trying to write one, but even that won't be as good as us being able to really share stuff. So thank you all so much for being here, and I hope it was some help to you. Thanks. Bye, Alexa.
All right, thanks so much.